Okay, hello everyone. I'm Dr. Sheena Sood, and we are going to talk about how to increase predictability in your clear aligner cases. And I am going to get started. So this is just a little bit about me. I graduated from the University of British Columbia in 1996 and became a dentist, and I was certified in Invisalign in 2002. And when I first started doing Invisalign, it worked really well. We were doing very simple cases. Everything was, it was easy, you know, everything worked really, really well. Over time, they came up with different attachments. We started doing more difficult cases. And over the years, I found that it wasn't as predictable. Things weren't moving as well. And I ended up going into case refinement hell, as I call it, where everything was case refinement, case refinement, case refinement. And I wanted to quit Invisalign. And very luckily, I was invited and asked to do the Reingage program with Dr. Arak, and that was very amazing. He's an amazing dentist, an amazing mentor, and an amazing teacher. He taught me how to do predictable movements, to know my attachments, to know how they moved, and to make my cases finish correctly and clearly. As a result of that, I became president of my Reengage group, which is a program that Dr. Arak runs, which is amazing and excellent. And that has really been a huge benefit to my Invisalign training. And again, through that, I was trained by Dr. Berik, who has an amazing Propel course. She's a dynamite speaker. And if you can ever hear Dr. Berik, I very much recommend it. I learned everything from her. I'd like to say that I am no expert in Propel. I'm just like all of you. And I think it's a procedure that makes Invisalign more predictable, quicker, and more profitable. And it's really actually quite fun to do. And also in 2017, I was appointed to the board of the American Academy of Clear Aligners. And we are having a summit, so to speak. Sorry, it's a convention, the Reingage Convention Conference in Vegas at the end of July. And I would recommend anyone who can attend. You can find out all about it on the AACA website. Berik will be speaking there about Propel. Recently, actually last month, I was certified with Digital Smile Design, and I started to do the beta testing with them and the Invisalign collaboration. So that was really cool. I mean, I've done a whole bunch of other things. I do a lot of cosmetic work. We do a lot of Invisalign in my office. I run a very, very big practice. But my main focus and my background, and what I would like to say is I'm very much like all of you. We're all the same. We're all dentists. And I know there's a lot of amazing dentists out there that could teach me a whole lot of stuff. So I would like to show you. So this is a disclosure. This is housekeeping. It is a bit slow. I am sorry. This is just how it is. I am not employed by a dental company. However, I do own stock in Invisalign, and not a whole lot of stock. It's $1 billion company. I am a dentist. So that is how I make my money. I bought stock in Invisalign because I know it, I understand it, and why would I buy something else if I can buy what I know? None of my family members have any stock or any interest. I have consulted and evaluated products for Invisalign and Propel. And this is like the commercial for the movie you see, you know, like the thing, this is G-rated. Anyway, I've been compensated in the past for consulting and or evaluating products for the sponsors, including Propel Orthodontics. For my participation in this event, I have received an honorarium from Propel Orthodontics. The opinions expressed in this presentation are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided are for educational use and not to be used for advertising or product endorsement purposes. This presentation has been approved for continuing education credits. No photographs, video, or audio recordings permitted during the presentation. Yeah, I love those things. Anyway, oh, this is me. Yay! So this is my fiance and I. This is what I love to do. The picture on the left was taken in February, where I went to Costa Rica to do a program with Dr. Arak. And I went to the Align facility, and that was my 4th trip there, and it's a really interesting place. So if anyone gets a chance to go, I highly recommend it. The picture on the right is of my fiance and I, and we're skiing at Whistler Blackcomb, which is about an hour from where I live in Vancouver, beautiful city. However, this is what I do every day. So this is me in my dental role. This is where I am right now. I'm actually in my office. So should you hear any like suctions and things going off in the background, that's why. It's a fully running dental office. So let's talk about micro-osteoperforation and high-frequency vibration and how this can help increase the predictability in your clear aligner cases. So this is the learning objectives. We're going to talk a bit about the science. I am not a science geek. I have a whole bunch of slides, but I'm going to just sort of go over them and hopefully you'll get a basic understanding. We'll talk about high-frequency vibrations closer to the end and how it helps your treatment time and how you can integrate the protocols in accelerated orthodontics. And then we can look a little bit at attracting new patients. So the whole thing about micro-osteoperforations are, what you're doing is you're creating a site of inflammation, a micro-inflammation site into the bone. And what that does, it stimulates at a cellular level the cytokines and the chemokines, which helps the cells differentiate into osteoclasts. That bit of inflammation, so we're using the body's own inflammation to help the bone remodel quicker. And as the bone remodels quicker, we get this, the bone, as it remodels quicker, the teeth move more easily through the bone. Okay, so we're increasing the rate of remodeling rather than increasing the magnitude of force. And this is what we get. We get a regional acceleratory phenomenon, the RAP, and it says it results in 2 to 10 times faster healing, and the effects last approximately 4 months. I would say 3 months. I mean, I think 4 months is a lot. Okay, so this is, I just want to show you this quick idea. This is the micro-osteoperforations. This is what they look like. So if you see the tiny little dots in the bone, the little red dots, those are where I have taken a little handpiece and made tiny little points where we've wounded the bone. I would never use that word with a patient, but I'm going to say it to you, dentist. And that has created a little injury to the bone. And that injury helps stimulate the cells, the cells in the bone itself to produce chemokines and cytokines, which causes cell turnover. This increases the rate of bone remodeling. And as the bone remodels, the teeth move faster and more easily through bone, and as well as more predictably. Okay, so this is a really good slide because this shows it all. So we inflame the bone by causing that little bit of damage. That increases the cytokine levels, which decreases the bone density. And we get an increased rate of bone remodeling and an increased rate of tooth movement. And this is huge. This is huge because we are using the body's own way of healing itself and the bone to remodel to increase the speed of which our teeth move. And as you can see actually in the corner there, you'll see that this was done in 1988 and 1985. We've known this for a while. And it's been around for a while. Okay, so this is from a study. I just want to show you this. This was done by Manny Alicani, and he's kind of the guy that's really talked about this. This is the same patient. So slide A is the same patient. We're trying to distalize the canine with a TAT appliance. So in the top row in A, you'll see on one side you've got the TAT appliance connected to the canine, and on the other side where it says ortho plus micro-osteoperforations or MOPs, that's the side where they did the micro-osteoperforations. On the left side, no micro-osteoperforations, and on the right side, yes. Slide B is 24 hours later, but what's really interesting is slide C. This is 28 days later. So 1 month later, you can see there's a significant amount of bodily movement of that canine on the side that had the micro-osteoperforations in the same patient. Okay, so this is another slide. I'm going to talk to you a little bit about the science. So now we're moving teeth through the bone because the bone is remodeling it. This is really interesting. With MOPs, they actually protect the root because as the teeth are moving through the bone and we're decreasing the bone density, the roots move more easily through the bone. If you move the teeth too fast and too hard, as we know, many of us have seen x-rays with root resorption, it's because there's too much pressure, and that causes a different kind of resorption where the chemokines and the cytokines and the osteoclasts are in the area for too long. By doing the micro-osteoperforations, we protect the root from damage because, as I said, we're decreasing the bone density. This is a really lovely slide showing this. Now, another slide. This is a slide of how well the teeth move with micro-osteoperforations and 3 days aligner changes versus 14 days without. So if you look at the two scans on the right of the screen there, you'll see that the teeth have moved relatively the same with CBCT, and you can see they're superimposed where the teeth were to where they've moved to. So with 3-day treatment and micro-osteoperforations versus 14-day regular treatment, we've got a similar amount of movement. I mean, that's huge, and I would say very significant to go from 14 days to 3 days. Okay, so now, like I said, I'm not going to spend too much time on the science. That was my science. If anyone has any questions at the end, I'm really happy to answer questions about the science. At least what I know. This is a great textbook. This is the editor is Mani Al-Akani. That was the fellow that was part of the study or headed the study where they distalized the canines, and they've done quite a few studies showing the Propel system and the micro-osteoperforation. Okay, so let's get into how we do this. So these are the two devices. On one side, you will see the replaceable tip driver. That's kind of a handheld device. I have one of those. I also have the one on the right, which is the power tip driver. Personally, the replaceable tip driver, I don't like. I've actually never used. But I know there are a lot of dentists, some of which teach, which really like it because they feel they can get a tactile feel to create the little holes in the bone. So if you see the little open, the tip that's there, they're disposable tips. There's an open and closed one. The closed just has millimeter gauges, and it helps kind of guide you through the depth because you're going through the tissue into the cortical bone. And really, you just want to hit that cortical bone and engage it. So the little lines on that closed one kind of help guide you into it. After a while, I think most people switch to the open because they get a very good tactile feel with that. Personally, in my office, I don't like it. I feel like I'm coming at my patient's head with a big screwdriver, and it's scary. And so I don't like it. As I said, it's what works in your hands. And I know a great many dentists really like that one. I really like the power tip driver. It's quiet, it's easy to position. It works very much like a handpiece in my hand. It feels very natural. It is very light. It's motorized, and you can see you can change the torque as well as you can change the speed. Honestly, I use the maximum speed and the maximum torque, but you can start slower if you want to. It's got great access, and those little tips at the top, they're relatively inexpensive. And the contra-angle, I actually have a couple of those because if we do a couple of patients in a row while one is being autoclaved, we have the other one ready to go. You can also use it for tag placement if you like. And I really like that handpiece. So this is the first and only product cleared by the FDA for use in micro-osteoperforation. It is the gold standard. So this is a great Propel slide. It shows us a lot of good information. You can use it for a lot of appliances. You can use it with a lot of what I'm talking about today is Invisalign because that is what I do. I have been trained to place brackets and wires. And I did do that for a while. I tried 6-month smile. Honestly, wasn't my favorite. I found it became 9 months or 1 year smile, and I had much more control with Invisalign, so I did actually stop doing that. But you can use micro-osteoperforation with standard wires or brackets, and it will improve the teeth movement again because of the quicker cell turnover and the bone remodeling. So you can see any malocclusion anytime. We don't have to worry about patient compliance. This is doctor controlled. We can do this for our patients, and it will last about 12 weeks. And so for 12 weeks, we have this movement occurring faster and more predictably. And you can read the rest of this. It's interesting. Root protective, as I said, pain reduction. This is really interesting, and I will talk about that as well. And we get ideal finishes faster. Okay, so this is a little slide that just shows the tips. So the design matters. You look at the tip that goes on the Propel device, you'll see how wide it is. So we're maximizing the macro fracture. The more damage, and again, I'm not going to use these to my patients, but I'm going to use them for dentists. The more damage or the microfractures that we're doing, the better the results. The more chemokines, the more cytokines that we're releasing, the more remodeling that we're getting. So you can see the wider tip at the top here, it doesn't break. The ones on the right there, which are not FDA approved, by the way, they're little. You have to go in further with the device to actually get it to do the same amount of damage. So you can see, and then you can fracture that one. The ones on the right, they're more for replacement, and they're really inexpensive, and I know some dentists are interested in using them. I think it's silly. The ones on the left, they're inexpensive relative to what you get for using them, and they're FDA approved and they're safe. And we really want to use the thing that's the best. Okay, so MOP FAQs. This is a great slide. So the effect is regional. In other words, this is going to spread. So when you do a little dot, a little insult, a little injury into the bone, the effect of the inflammation will spread 6 to 10 millimeters around that area. And so that means if you've got roots that are very close together, because you're making these little perforations in between the roots of the teeth, and you know, sometimes the roots are so close together, it's not, you don't feel really comfortable positioning your instrument in there. It's okay. You can be distal or mesial to that area, and because the effect is spreading, you will get that benefit. So how many? Remodeling is proportional to insult. So the more we do, the more remodeling we get, the faster the teeth move. I try to maximize the amount, but also keep my comfort in mind, because, you know, it is, you're sometimes you're really close to roots and you've got tissue and all kinds of things. So I try to do at least 2 or 3 perforations per area if I can, and I will show you a slide of that later. So how deep? You know, near the molars, if you want to do the molars, I generally go premolar forward. As a result of my training, I try not to move molars, and molars are anchors. So we don't want to create injury or inflammation around our anchor teeth because we don't want those to move. Those are the ones that are helping us. So generally, I don't go to molars. However, if you did want to move molars, you would go 5 to 7 millimeters, say, around the molars, but maybe 3 to 4 or even 2 around the anterior teeth, because you've got a thinner amount of tissue. So basically, you want to go through the cortical bone, and that is a feel thing. When you engage the handpiece, you feel a little bit of tug back, and you can feel it click, and you get better at it, and it doesn't take very long. Most dentists are pretty, we have very good tactile sense. And so once or twice, you pretty much have figured out how far you need to go, and you get a really good sensory feedback from your hand that tells you, okay, here I am. Okay, so this is contraindication. So this is from Dentistry Today by Brian Gray, he's an orthodontist, and this is from October 1st, 2014. These are the people you don't want to treat, or with some added things. So for instance, patients with bleeding or immune disorders. We don't want to treat those people for obvious reasons. Patients with high anxiety. So I would actually treat these patients, and I have. However, I would use some form of sedation, whether it's nitrous gas or oral sedation. If you don't need a real heavy sedation, but these people are definitely easily treatable. Again, patients requiring prophylactic antibiotics, I would treat those people as well, but I would give them antibiotics prophylactically. However, patients taking or with a history of bisphosphonate use, I won't treat. Patients taking anti-inflammatories, because there's really no point. The anti-inflammatories block the inflammation we are trying to create. I would still do orthodontic treatment on those patients. However, they're not really going to get the benefit of the Propel, and they will take longer, and their treatment will be less predictable. So if we're aware of the medications our patients are on, at least we can inform them of that. And then patients who have had previous radiotherapy of the jaw. Okay, so how many do I do? Okay, so you can see this is sort of like a guide of where you can put them. So for instance, the single tooth, you can do 2 to 3 on either side of the tooth you're moving. You can do 2 per quadrant. And if you look in that lower anterior area, sometimes we're just doing 1 around the roots of the teeth, or if we can get 2, great, the more the better. But sometimes the roots are so close together that you end up doing less. But remember, you're getting that 6 to 10 millimeter spread, so that is fine, and it will work really well still. Okay, so this is how I kind of discuss MOPs with my patients. So my goal is to have my patients set up for success. I want them to succeed in orthodontic treatment. I want them to get a good result. And if I can give them a faster, more predictable movement, I know that they're really set up for a good, successful procedure. And so I try to use words, just like every other treatment that we do in dentistry. I want to use something that makes it sound palatable to the patient, where they feel comfortable with it. We don't ask them if they want it. We pretty much say, this is how we do things. We're going to accelerate your treatment. and this is part of the procedure. We do not charge extra for it because the financial benefit to doing it is so great for us that there is actually a friend of mine, Dr. Kevin Bauer, who would suggest that you should charge more for patients who don't do Propel, which is really an interesting way of looking at it, but it's true. Once you use this treatment or MOPs, you want to do it all the time. So I describe Propel as either tapping the bone or like acupuncture, and that depends on the patient. For instance, some patients don't like needles. I won't use the word acupuncture. I'll use tapping on the bone. Other patients, they really love acupuncture. They're related to a spa treatment. And I say, you know what, we're just like it's acupuncture. You know, we're creating a little zone of inflammation using your body's own healing system to help your teeth move quicker and in a more controlled way. I say to my patients, you will be numb for the Americans and frozen for the Canadians. We use the word frozen. And so you won't feel any of it. And I tell the patients not to book meetings or a dinner out or work where they'll have to interact with people because they're going to be numb, and their upper and lower front teeth and premolaria will be numb, and so will their lips. The pain is minimal in my experience. Usually I tell the patients it's going to feel a bit tight afterward. They might have some soreness for 24 hours, and it can be treated with Tylenol. But remember, we don't want to take any NSAIDs or any anti-inflammatories that can affect the Propel treatment. We want that inflammation there. We're taking advantage of that inflammation. There may be some bleeding after the treatment, which can accumulate in the trays. I learned that from my patients that went home and were like, oh my gosh, I looked at my trays and they were filled with blood. So now I warn them and I say it'll look like a lot, but it's just a few drops. I think that's actually a rebound effect from the anesthetic that we use, the epinephrine, because I found in the office very often they'll leave with no bleeding, but like a couple hours later they'll see it, or an hour later. And so I just warn them and then they're fine. And then tomorrow they can return to their normal activities. And I tell them to call me if they have any questions or concerns about that. So this is kind of how I do it. This is a great Propel slide. I kind of mix it up a bit. So I have my x-rays up in the room when I'm going to do this. I have the patient rinsed with chlorhexidine. I personally like to put my attachments on prior to the rinse and prior to the anesthetic. I have two assistants that are trained in orthodontics, and they are allowed to put the attachments in, which I go in and check. So I will leave them in a room with the chlorhexidine. They will put the attachments on. The patient will rinse. So by the time I come in there, the x-ray is up, and I can look and palpate the roots, and then I will anesthetize the area. So this is a pictorial display. Yes, this is my office. So we have the two 1-minute rinses. So a swish around for 1 minute and then spit it out and then again. And I like to put them on a timer. I really hope my assistants are doing that, but sometimes I'm not in the room. So we're doing this. Okay, and this is kind of the setup that I use. This is, you can see my autoclaved contra angle, my Propel driver, and the little disposable tips. I like to leave it in that box, or it's in a plastic sheath, kind of the way implants come. I like to keep it sterile until just before I do the procedure. I often will use the Optia guard that's there in the corner there that we use for, it's an Ivoclar product that helps like separate the lips and the cheeks. So then we're going to anesthetize. And you can do 2 infraorbital blocks, and that kind of covers the upper area, and 2 mental blocks. I kind of do infiltration personally. I like to go above the canine, a little bit further back, and then around the lower canines, a little bit further back and a little bit further forward. And you know, about 2 carpules. A quarter carpule in each quadrant is really helpful. So there are the attachments. They've previously been done for my patient, and I will do the interproximal reduction. I like to do that when the patient is frozen or numb, because then they don't feel it. It's a pretty awful procedure for my patients. We do it by hand. I use the Galler technique for spacing, and it is very precise, very predictable, but it is not the funnest thing for the patient. And when they're frozen, they kind of like it better. And now I'm looking at the radiograph. I like to look at the radiograph, palpate the area I'm in, and then palpate again, and then position my handpiece. And I'll kind of go back and forth between the radiograph and palpating as I'm going along. And once I've kind of found the area between the roots, then I start my micro-osteoperforation. So I am holding the handpiece with my right hand because I'm right-handed, and I am using my left hand to kind of guide the head. And this is a better view of that. If you look here, you will see where I'm guiding the handpiece. You can see I have done a micro-osteoperforation in the attached gingiva. That is the ideal place for it. And now I'm going down into the mucosa. Now, the one thing about the mucosa is it will wind around the handpiece. So if you look, I'm kind of pushing the obtrugate, the retractor thing, down with my thumb. And I'm using my hand to help support the patient's chin. And in my hand there, you'll see there's a 2x2 gauze that's soaked in chlorhexidine. I really like chlorhexidine for this. There's been some controversy about if it slows down wound healing or not, but I've been using it for years, and I love chlorhexidine, and I put it everywhere and on everything when I'm doing stuff intraorally. So here I am doing 2 perforations in this site. And you can see this is a really good slide because it shows the angulation to the mandible. You really want to get it at a right angle. You'll find if you're having to push too hard or go too deep, it's just the angulation is wrong. And you have to think about if you're at a 90-degree angulation, that's the most ideal point to be at. So, and this is what it looks like 5 minutes after I've done it. Like literally the areas start to heal so quickly. If you look on the between the lower right canine and the lower right premolar, those areas are not bleeding. They're almost starting to close. You can kind of see a couple of little fine lines there where I had done the MOPs. And, that was probably the first area that I did, and they're already starting to close. And I've done almost 2 on every single site. So where you see those little tiny dots, that's what they look like. And, I will even show my patients after, and I'll say, look, and they'll be like, oh, wow, like it's like nothing. And they heal very quickly. I would say 24 hours, and the patient is pretty happy. I mean, it's a little bit longer. Okay, so now I'm going to switch gears here, and we're going to talk about how long to tell patients to wear the trays, or, we're going to give them some guidelines. And micro-osteoperforations will help the teeth move more quickly, but we still need to take into account how difficult is the movement that we're doing. So there is a difficulty movement chart that Invisalign gives us. And like I said, I do a lot of Invisalign. That's what I do. So this is what I'm most familiar with. And you'll see you can see my little pink arrow, and I'm clicking on the treatment screen. If you click that within the patient's file, it will produce it'll give you 3 printouts. It will have the attachments, the IPR, all that other stuff, but we'll do this, which is the tooth movement assessment. And it will show you, if you see the little X in the lower or kind of below the tooth chart there, it says missing tooth pontic, and then there's a blue square that's moderate, and then like a purpley black, I think it's meant to be black, but it looks purple on the screen, that says advanced. So those teeth will show up highlighted. So on this particular case, you can see that 4-4, I'm Canadian, so that's that lower right first premolar, is got moderate difficulty. That is the tooth that is going to be the hardest to move in this particular case. The white ones are easier movements, and so they are not going to limit us, but that blue one, that is going to be the rate limiter. So we judge how long the patients will wear their trays based upon that particular tooth. That's going to guide our treatment, and we're going to use that to help us. So this is my preference at the moment. I will say I do adapt this, and I do change it regularly. Just as I get more experience using this, I kind of update it. I do like to test some boundaries. So there's a very great orthodontist that I heard, Dr. Shipley, Thomas Shipley, I believe, and he has a great lecture. He does 3-day aligner changes. Now, I did try that. I did lose some, I felt like I didn't get proper, like the teeth didn't move well. And so, I lost some treatment. I don't know. It just seems like they weren't lining up properly. So I switched back to 5, and I'm happier. I'm going to go back and try some simpler cases with 3. I think I might have been just a little bit too aggressive. So the simple, straightforward movement, the ones that are white, we're going to do, and this is all with micro-osteoperforations, we're going to do 5-day aligner changes, or I'm going to do 5-day aligner changes. If I added a VPro, the high frequency vibration, I would consider 3-day aligner changes. I've only tried 3-day with 2 patients, and I wasn't super happy. Mind you, their cases still finish faster because even though they're doing 3 days and they need to go into refinement, the cases finish really quickly. So I didn't really lose anything. I just don't really like to do refinement. So now we're going to go into the moderate. So if you remember the slide I showed before with the difficult tooth that was there, not difficult, but the moderate difficulty tooth, this is that patient. So with micro-osteoperforations, we're going to do our MOPs. We're going to do 7-day aligner changes. With the VPro, added with the VPro, I will do 5-day aligner changes. Now, VPro does require some compliance. VPro is a vibrational device. I will show you at the end. That does require some compliance. And so some dentists don't like to use it. I think for patients, and I hope I'm a good judge of character when it comes to my compliant patients. I will give them the VPro and I'll say, you know what, let's just do 5 days. And if they say, oh, I don't know if I'm going to use it, then I'll say, well, we'll do 7 days. Now, difficult black movements, these are the really, really tough movements. Even with MOPs, I'm doing 10-day aligner changes. I almost want to do 14, but right now I'm doing 10-day aligner changes. If I add a VPro for a compliant patient, I will do 7-day aligner changes. And I'm praying, because those movements can be really challenging at times. And they're the ones that limit the rest of our treatment. So also, if you look at the note there, that the more MOPs I do, the easier teeth are to move. So if I have more difficult movements, for instance, that premolar intrusion that you saw on the previous slide, if I do more MOPs in that area around that tooth, maybe 3 on either side of that tooth and in that area, it might help my teeth move faster, and so I'm going to do that. So I'm going to use that tooth movement assessment chart to guide that. Okay, so now we've decided how long, based on the difficulty of movement, we've decided how long we want our patients to wear their trays, whether it's 5, 7, or 10. Honestly, I hardly ever do 10 days. I very often will go to 7 days and use the VPro and or have them really chew. I use something else called Munchies. They are also an accelerator. They're a medical grade rubber. They're like a little triangle, and they're wonderful for seating aligners because they help the tray engage, right? They help the tray seat better. So you don't lose the fit of the tray during the treatment. Now, to generate the aligner schedule, if you go, before you open the ClinCheck in a patient's file, you'll see additional services on one side. If you click on that, a drop-down menu comes. And you can see my pink arrow. You'll see it says Generate Aligner Schedule. And right here, this is the Generate Aligner Schedule. And from that, it will ask you a couple of questions. It will say, how many trays are there total? So we'll say there's 14 trays, you click 14, or 10 trays, you click 10, and how fast do you want to change these trays? Or how many days between tray changes? And we'll say 5. So here I did this, you can see I did it on May 14th. Here are my 10 trays that I'm giving, and this will give you all the dates. So you can give this to the patient and you can write it on each of the trays so they know when to change them. Sometimes I will ask my patients, put a reminder in your phone for these 10 days so that they get a little reminder or a message to remind them to change their trays. Okay, so I'm just going to show you a few little cases here of, what you can do with Propel. So I have a patient, I actually did those veneers, I think 12 or 14 years ago. And they were fine for a while, and she disappeared, and I didn't see her for hygiene or anything. And she came back and said, oh, I've chipped a veneer. I want you to fix it. And I said, yeah, great, no problem. But we know why this happened, because we know that teeth move measly towards each other over time. And you can see that lower right central, the lower right central incisor has kind of rotated out, and it's moved buccally, and it's catching the corner of that central. So I can replace that veneer, but I'm hesitant to because I know that that's going to happen again. Patient very happy with the smile, just wants to replace her veneer. So we decide to do lower anterior treatment only. So the only way I can move teeth that are in this position where they're crowded, and you can see they're super erupted if you look at the gingival height, is to do some IPR, interproximal reduction, and move the teeth just at the front 6 there. So sorry about the slide. It's a little bit white and a little bit crazy because I was doing it over the chair and I was mid-treatment. Where I've done all those micro-osteoperforations or the MOPs, you will see it is mesial to the canines because those are the teeth that I'm moving mostly. And what's really interesting about this, so you can see I've done some in the attached gingiva as well as some in the buccal mucosa. If you look at that mucosa, it's really interesting. It's not even bleeding as much as the attached gingiva, which I find really interesting. Okay, this is another case. Look at the mandibular tori, or the tori, the bone. These tuberosities are intense. But this is a great case to do it on, and I'm going to show you. These are the perforations I did. And again, I did them in the mucosa, and it was fine. And if you look around the teeth, this is right after, so some of them are still bleeding. I would say within 5 minutes, all of this should stop, and the teeth will, the gums will look great by the next day. The other thing I wanted to say is I have noticed, I used to, prior to doing the MOPs and Propel treatment, I used to give patients their trays, and a week later, I'd have them come back for their attachments, their IPR, because I found the trays were so tight and painful, I wanted a week for them to get used to it. As a result of learning from Dr. Berik and her BAM technique, in the very first appointment, on the very first day, I am doing this. I am freezing the patient, after their records appointment, so now we're inserting their trays. I am freezing the patient, numbing them. I am doing the interproximal reduction, I am placing the attachments, and I'm doing this Propel and giving them their trays to wear. And I thought patients would be in agony and a lot of pain because I had seen that before. I have found my patients have less pain now with this. And so I find that these actually, the inflammation starts right away, and they measure the inflammation by the cytokines and chemokines in the clavicular fluid. And it's been shown that you get a huge release within the first 24 hours. And the pain, even though there's all this inflammation that's occurring, is actually gone down. So my patients are more comfortable after I do this treatment than if I never did it at all, which I find fascinating. This is a Propel slide. This is 30 minutes after. You can hardly see those little dots. This is a very cool procedure. I will say I have enjoyed immensely doing it because of the fact that my patients' teeth move faster, they move more predictably, and they get a good result with less pain. And it's root protective. Okay, so my post-treatment, I call or text patients the next day. I've actually started to text them a lot. I used to call them. Anytime I pick up a needle and put it in someone's mouth, I am calling or texting my patients. I found text is really, really responsive. People sometimes, or dentists, feel a bit weird about text, but patients love it. It's easier for them than having to pick up the phone and call back. And you can get a response even if they don't see it right away. You can get a response a little bit later. So, at their appointment, I say, okay, do we have the correct number for you? I might send you a text. Is that okay tomorrow, just to see how you're doing? And patients love it. Great practice builder, and it's worked super duper well. I tell patients you may experience some tenderness around the site for 24 to 48 hours. Honestly, I tell them most of the time it just feels a bit tight. Where I do get pain is where I put the needles in. That is the most painful area. And I tell patients, I say, where I put those needles in, not while I'm doing it, but at the end of the treatment, I'll say you might be a bit sore around there. If they do have pain, they can take Tylenol, but no Advil or Aleve, no steroids, nothing that's going to stop that inflammation. We really, really want to keep the inflammatory effect in process and during their aligner treatment. So I advise against Advil and Aleve for the duration of their tooth movement, which patients are okay with. Okay, so now let's talk about, we're switching gears again. Now let's talk about vibration. So this is the EPro device. It's amazing. Okay, so here's some little scientific facts. So they did some studies. Here we go. We're looking at this study done by Alan Sari. And these were, if you look at it, so the sham is a device. It's a EPro device that's not effective. So it's not working. So they started doing, they had 3 groups. One group had 5 days with the EPro. One group had 7 days with the EPro, and one had 5 days with a thing they thought was working, but it wasn't working. And you can see they had superior tracking with 7 days plus the non-functional appliance compared to, the EPro with 5 days had superior tracking to 7 days with the non-EPro, and it had the same tracking as 14 days. So you could go 5 days with the vibrational device and 14 days, and you get the same results. But if you did 7 days with the EPro, you get better tracking than all the groups. And the 5 days they had to discontinue because they were changing their trays so fast, the teeth didn't have time to move. Because we're not doing any MOPs here, we're just using the vibration. This is the increased rate tooth movement. Now, what's really interesting is so the 14-day group, they had a 40% slower, which is kind of interesting relative to the reference, which was the 7 days with nothing. Okay, that was their reference point. So 14 days had slower movement, which is, I haven't totally figured that one out, but we'll go with it. for 7 days with the VPro, we had 28% faster, and with 5 days, 68% faster. But if you look at the tracking, I would say the tracking is better with the 7-day and the VPro. But remember, we're not doing any micro-osteoperforation. So we're getting an increased rate of tooth movement. Here you go. You can see the 7 days. That's great tooth movement. Okay, here we go. So compared to other vibrational models, which require 20 minutes a day, and I have used those, it does require a lot more patient compliance. So 5 minutes is a lot easier. So if you look at for 5 minutes a day, it can improve the accuracy of the aligner seating. You get reduced pain and discomfort, and they can measure you get increased bone remodeling because you can measure the cytokines. So they can measure it from the gingival fluid. This is really interesting. This is from Thomas Shipley, the orthodontist. He had a patient that finished treatment, and at the end of treatment, you can see his teeth were straight. 1 year, he had poor retainer compliance. He's a teenager, surprise, surprise. And they tried to put the Vivera back in, and it didn't fit. It was too painful. And the father did not want to proceed with treatment because the second child is now due. So they added a VPro, and on the same day they added it, they managed to get the tray down. And then 4 months later, the tray was seated and the teeth were back in order, and the dad sent the second child in for treatment, which is really interesting. And I've actually used this a few times on patients when they tell me, oh, my teeth have moved. I wear my retainers every day. And I say, okay, bring in your retainers. I give you a set of 4, bring them in, let's see them. And most of them, no, they've not been wearing them, and they try to put them in there tight. And then I hand them a VPro and the retainer seat. And I say, all right, now we're going to give you this VPro. And I will give it to them. I'd rather not reopen their case for the cost of the VPro. It's inexpensive. I'm like, here, take this and don't come back. Well, come back for your cleaning, but don't come back to see me for a time. Okay, and this is a pain relief slide. This is really cool. So the VPro, you can see from the baseline to 5 minutes with the VPro, they had significant pain improvement. So you're handing the patient the trays, and you're giving them a VPro, and they're getting less pain using it. I will say that has been my experience with my patients, that they find it they're much more comfortable with the device. It sort of makes the area feel a bit numb. This is extended pain relief. So you can see after 7 days, the pain drop was significant, with 5 being the pain score from like 1 to 10. Starting at 5, it dropped way down to almost 1 with the VPro, but it was almost like a 2, 2.5 without it. And again, this is without MOPs. So this is reduced treatment time, and the reason is we're getting our aligners to seat better. We're getting some chemokines and cytokines released, so the teeth are moving faster. Okay, now this is the only vibration product to support an active treatment and retention, so we can use it for retention as well. So after we have the aligner seated, then it will help with pain reduction, refinements reduced, treatment time reduced, bone remodeling increased, and retention bone density increased. So remember, there is a cycle of bone remodeling. So we want those osteoclasts to help our teeth move quickly, but we want those osteoblasts, which are a little bit slower. We want them to come around at the end of treatment when we have the teeth in nice position and build bone. This device, just like the MOPs, it helps the bone build as well as it helps it resorb. So we're using the benefit for both treatments. Once the teeth are still, and now we don't have that active force, now we're using this because you're going to get less differentiation of osteoclasts when you don't have the force on the teeth. Now the teeth are still, and we're going to use it to build our bones. And that's what it looks like. It's a very cute device. You look very high tech. I have had some interesting patients that have done research online, and they're like, oh, you're going to give me one of these students. That's what I wanted. It's so cool. And they love me for this. They think it's absolutely wonderful. This is what it looks like in the mouth. So you're going to wear it with the trays. The patient's going to wear it with their trays, and they're going to wear it for 5 minutes a day. Sometimes I'll tell them to do 10 minutes. You know, if I'm a little bit concerned, I'll say 5 minutes in the morning, 5 minutes at night. That does require some compliance. So I often will say, you know what, keep it in your car. It's got a charger with a USB port, so you can charge it if you need to. The charge lasts a long time with these, though. And I'll say, just do it in your car. Drive to work, put it in. It will turn itself off after 5 minutes. And you can have it. And I try to make it as easy as possible for my patients to use the device I'm giving them. I also tell them to, and again, I learned this from Dr. Berik, is to eat with their trays in their mouth, which is unusual for some dentists. And I know I used to tell my patients very often, take them out. But our patients, this is when they're going to lose compliance. This is when they're going to forget. They take them out to eat. And when they take them out to eat, they forget. They put them in a napkin. They start tasting food. So I say, eat, drink with them, do everything with them in. If you want to take them out to rinse, you take them out, you put them right back in your mouth. And they may get kind of yucky and gross, but that's okay because you're going to get a new tray in 5 days. So you're getting a brand new clean tray. When they were wearing them for 14 days, this would have been atrocious. But for 5 days, this is totally doable. And because people are eating with their trays, it's just like using those munchies, which are really great at seating your aligners. As you are pushing on those teeth, the trays are really engaging the teeth well, and you're getting better movement. They're holding the teeth, they're holding those attachments, and the teeth are moving in a really predictable way. So this device, the VPro, the high frequency vibration system, you assign it to a patient, and it's got a really cool thing. You can plug the USB into a computer, and it's got this user snapshot, and it will tell you every day you did it, so patients can keep track of it. And you can also do it at their patient appointments. I don't, honestly. I am not going to track their appointments. I can normally tell how well their trays are fitting. But, sometimes you say, oh, I'll be able to track it. Bring it in when you come. And maybe that makes them compliant. I don't know. But I really try hard to make them think that I'm checking this. So this is kind of how it works. It's got a little light on it. It makes it look super high tech. It's pretty cool. With the way our offices are structured these days, and we can differentiate ourselves by being a high tech office. Everybody loves that stuff. And, I've got a couple of intraoral scanners. I've got my iTero now. I know there's the two new ones. I've got a Dirac, and I make my in-office crowns here. And I try to keep up with technology as it comes in. And digital smile design is a whole new level of technology for me. But giving this to your patients, they get intrigued by it. And, honestly, even if they don't use it, it's a real practice builder, because this plus accelerating the treatment and telling the patients, you know what, you're going to be done in 3 months, or 4 months, not a year. Your friend is going to be a year in treatment, but we're going to do it in 3 or 4 months. And with the device as well, the patients get really excited. I think I forget how cool this is for some of my patients. And I only remember when my patients, they look at me and go, wow, this is so amazing. I'm like, yeah, I guess it kind of is. This is pretty cool. So the blue light, it means it's vibrating. 5 minutes, the cycle's in progress. The magenta means low battery, let's charge it. Amber, we're plugging in, we're charging it. It looks like a little cell phone charger. When you get the device, you plug it in the wall. It's very intuitive. Patients can use it very easily. Green means it's fully charged. And I would say fully charged lasts for a few days. You don't need to keep recharging this. It holds the charge super fast. You can rinse off the plate you bite on and clean it, and it separates, as you saw in the last slide. You can pause it. So if you pause it because you need to do something, it will pause and if you resume within 30 minutes, it will finish the rest of the 5-minute cycle. So you turn it on, it will have a 5-minute cycle, it will turn off. If you pause it by holding the button, it will pause, and then it will refinish the 5 minutes. Over 30 minutes, it's going to do the whole 5 minutes again. That's fine. As long as they're using it, I'm super happy. Okay, so now I'm going to show you some cases. This is kind of fun for me. These are a couple of really interesting cases. I'm also going to show you a couple cases my associate did. And the reason I'm showing you those is she has only been out of school for 2 years. And she's also a Gallery Reingage graduate, which is amazing. So I'm lucky to have her. And, she does this every day in and day out. And I give her a lot of the aligner cases to do now because she's got pretty good knowledge of it. And, the reason I mention this is because she can do this, and she does it really effectively and really well. So I want to show you a couple of her cases because I'm pretty proud about that. This is a patient of mine, actually. So this is another of my associates' best friends. And this best friend, she has 2 teeth, supernumerary teeth that are in her bone. She's definitely afraid of the dentist, and she lives about a 6-hour flight away. So we set her all up with the oral surgeon in the office, and she's very scared. So we have a dental anesthesiologist brought in, and she is going to be sedated for the removal of these teeth because one is impacted in the bone. And I am going to do the Propel and the micro-osteoperforation, the IPR, and the attachments while she is sedated, or she's actually just coming out of sedation because we didn't want to leave her in for too long, but she was still kind of out of it. Okay, so this is her before smile. So you can see she's got a central that is really far out and it's holding up her lip line. So this is kind of the biggest smile I could get her to do. She really didn't like her smile. You can see a constricted arch form there. This is a retracted shot of her teeth. She's not doing a super good job taking care of them, but this was at the records appointment, and you can see that tooth. It was actually quite far out, luckily. And this is her arch form. So you can see how far that tooth is and how narrow her arch is. So she came into town just for a checkup appointment, and this was a month and a half later. So after a month and a half, look at the movement that we got. Look at how much wider her arch is. Look at how nice that tooth has moved into place. It's not 100%, but she is mid-treatment. I think she's almost at the end, though. Honestly, I think she's almost at the end. So this was her lowers, and you can see that little supernumerary tooth that was removed. This was at the records appointment. This is the month and a half later. So we've really got some good movement occurring. Everything is starting to level. It's healing. It's looking better. This is where she is now. Now, those two lower incisors, you see those two, how high they are? We really want to intrude them. Intruding those incisors, intruding teeth in general, very hard movement. We are pushing apices, roots of teeth into solid cortical bone. This is a tough movement to achieve. And align the tooth movement assessment chart. It doesn't always show you that as a difficult movement, but remember though that it is. Anything with root, torque, bodily translations, intrusions, those are difficult movements. And I would treat them as such. Even if I see them in white on the aligner sheet, I will call that a difficult movement. So this was the month and a half later, and you can see she's got those teeth have significantly improved. I mean, this is a big deal for a month and a half. In the old days, before MLPs, this honestly probably would have taken me 7 or 8 months. And this is pretty spectacular. Again, she's not finished. This is her before smile. This is her smile now. Now she's doing a much bigger smile. Her lip is much better. It's a much better position. We do have the anterior open bite. We've got an anterior interference on those lower two incisors. And this is why. Do you see how those aren't intruded all the way? They are much better. They're in a better position. But again, this is a tough movement. This is the aligner seating. This is at the checkup. She just came in. And you will see we've lost tracking on that lateral. In fact, the lower two laterals, you can see they're not fitting well because those two central incisors, they haven't intruded properly. So they're catching on that tray and they're not feeding all the way down. In retrospect, what I would have done is, what I would have done is I would have done some, let me go back one slide. I would have done some more micro-osteoperforations and around the apices of the teeth to create some more inflammation there. I'm not super comfortable with that. I haven't done it before, but I am going to try it. I'm going to do it with a CBCT just to be sure though. And what I did do though, because she was quick in and she was rushing off to the airport to get on a flight to go home, is I did add a VPro. And which I hadn't done before because she was sedated and I couldn't go over the instructions with her. So I gave it to her and I'm going to see how she is. Because you saw with that Shipley retainer slide how well he got those retainers to seat down. So I'm really hoping that this will re-engage that particular tray and we might get some good movement there. Okay, so let's keep going. So this case, a month and a half later, this was 1 month later. This patient, 1 month later, she still hadn't finished. She said, no, I'm done. I want to stop. This was in 1 month. And the only reason she came in was you can see her gums are kind of irritated there. They were rubbing on there. And she said, oh, you know what? My gums are irritated. I want to stop. And I said, you know, you've got a couple more trays. And she said, no, I'm done. I'm happy. The one central there, it was root canal, which is why it's a little bit different color. Okay, this is a patient of my associates now. So this particular patient, this was her before. This was 9 months later. Great case. She leveled the lower incisors a bit, but she didn't want Propel at the beginning. So this treatment, we did it halfway through the treatment. So I was brought in and we talked about it, and my associate talked to her and she convinced her to do Propel, and she was thrilled when she did it because the treatment, it would have been finished in 4 months had she started with Propel. It did take 9 months instead of a year and a bit. So we still got a good result that quickly. This is another, this is the same case. So this is with the Propel. This is a patient who had Propel from the beginning, and 2.5 months later with a little bit of bonding. This is great. Look at how much better, and obviously bleaching. We did bleach her teeth. So this is kind of like 2.5 months, you know, for a patient to go from this is huge. I mean, this is life-changing. And when you see the excitement in people's eyes and in their face when they're like, wow, I never believed that this was possible. This is a big deal for a lot of patients. You know, they really, really enjoy this, and it makes your practice just happier, and they tell all their friends. Okay, so now we're going to talk about this is how we're going to attract new patients. So not only are we giving our patients a great result, it's faster, better, easier movement, and it's more predictable. We're going to have significantly less pain. I mean, I can tell you from my clinical experience, since I started doing this with MOPs, I put a question mark there because I see it. I actually believe that this is true, and I think it is necessary. I didn't read a study about it, honestly, but I believe there is one out there. Somewhere I might have read a reference to one. And now we're going to do 3 to 4 months of treatment versus a year or more. We're doing 3 to 4 visits with our patients versus 8 to 10. And remember, you know, these people drive in from far away. They miss work. They miss school. They have to come and see us. They don't want to come and see us. They would way rather be done quicker and faster. And it's better for us. The amount of chair time we save is ridiculous. And it makes us so much more profitable because we have less refinements and fewer appointments. And, you know, I used to say, so this is us and we're new and we're dynamic and we're doing this and no one else is. Honestly, I think it's the standard of care now. I mean, I really have started to feel that if you're not using one or the other or some kind of acceleration, whether it is a munchie, whether it is high frequency vibration, whether it is micro-osteoperforations, you're not really giving your patient the best that you can. So, you know what? At the end, happy patients refer everybody they know. And, oh, that's my slide. It's not playing. It's supposed to do this cute little dance. She does this dance. It doesn't work. Oh, well, she does a little jump up and down, but for some reason my slide has not decided it doesn't want to work. And it's super cute. But anyway, that's it. That's what I have to say. So if anyone has any questions, I'm happy to answer them for you. Thank you for attending. I really appreciate it. And I hope you learned something from this. Okay, and I've got a couple of questions here. So what is the max speed and torque on the Propel device? Okay, the max torque, I believe, is 30. And the max speed, is it 10,000? You know, I don't remember. I know I have it 6 to 10. I can look it up and I can get back to you, love. If you email me, and I'm sure I can provide that to you or someone at Propel can, I will get that for you. What happens if the roots are too close and root perforation occurs during micro-osteoperforations? How can we correct that? So far, that hasn't happened to me. I'll tell you what I do is I palpate the roots and I make sure that there's enough space. Remember, you get the spread over the area, 6 to 10 millimeters. So if you are unsure at all, just skip that area. You know, don't risk it because you don't want to perforate a root. I mean, really, they say that if you go into like the ligament that I don't think there's any real studies, but there is some evidence. I read that somewhere to show that if you go into the ligament area that it will heal and it's no problem, but I really don't want to perforate a root. So just, you know what, if you're unsure, don't do it. Concerned about doing MOP, this is another question, in the mucosa. It winds. What's the best way to prevent? Okay, the best way is you've got to stretch that tissue as tightly as you can. It will wind a little bit. And you want, honestly, that's okay. It winds a bit, you get it in, and then you unwind it, and you'll see it's kind of a little bit of a laceration. But you know what? It heals really quickly. And I haven't had people reporting a lot of pain, so I'm pretty happy to do it. Okay, question. I feel this might be a silly question. Never. It's a great question. But the infiltration injections you are doing, is the point to numb the tooth, or are you trying to numb the gum tissue? I am trying to numb the bone and the gum and the whole area that I can. So if the teeth get numb, great. The more numb, the better. I would rather have my patients more frozen than less frozen. So I really make an effort for them to be super frozen or super numb. I want that. I mean, the teeth don't need to be numb because they're not really affecting the teeth. So if you're a little bit lighter than what you would do, say, for a restoration, that's okay. But I would suggest that my technique is I use Septicane or Articaine with 1 in 200,000 epinephrine. It numbs everything and they're comfortable. I just want them to be comfortable. Okay, next question. I'm doing micro-osteoperforations in the attached versus both, not doing in the mucosa. Yeah, that's fine. Remember, you're going to get the thread. The more you do, the better. If you feel uncomfortable in the mucosa, that's okay. You know, start doing it in the attached gingiva. a lot of people are really happy to stay there. I find if I go down a little bit more, I don't know, I feel like I'm getting more inflammation, more cytokines, more chemokines, more microfractures, macrofractures, and better movement. Did you mention to improve effectiveness of intrusion, you would do more sites toward the apex? I did mention that. I have not done that, but I've read some really interesting studies about it. So the reason I haven't done it is I'm a bit hesitant. I'm kind of a bit like cautious, you know, I'm a bit nervous. I don't want to do any damage, but the concept makes perfect sense to me. So I think I'm going to try it with the CBCT. I'm going to have to like find a very good patient of mine that will be my guinea pig. And I will say, right, I'm going to use you and I'm going to try something totally new. I'm pretty comfortable doing that though, you know, and it will have to be a patient that trusts me to say that. But yeah, if you do it around the apex of the teeth, apparently, according to the study I read, they will intrude better. Can you intrude maxillary anterior teeth into the alveolus that is narrow apically than the root? Yes, you can, because the bone will remodel. So if you think about it, bone is remodeling constantly. And so, yes, you can reduce the gummy smile that way. That is a great question. You can intrude those teeth and the gum will go along with the teeth. Orthodontists do it all the time. Can you use topical compound anesthesia for these procedures? You can. I suggest, I know orthodontists, they really don't like giving needles because they're not used to it. You can use really strong anesthetics, and I know there's a great many orthodontists that do. I'm used to needles. I'm happy to give them. My patients don't feel anything, so I choose to use it, but you could do it with a really strong topical as well, and it would be great. I haven't done that. It's just that I'm really comfortable doing it with needles. But you know what? I say what's really important is to get the results, the teeth moving really quickly. And if you can do it with topical and the patient's not feeling anything and you feel comfortable, go for it. You know, you're giving your patient the best. So it's awesome. And I think that's the end of the question. So if anyone has any questions, any more, great. Otherwise, thank you very much. It was a pleasure for me to do this for you. I hope I didn't talk too fast. I have a tendency to do that, and I wanted to just say that if any of you would like to learn a little bit more about clear aligner treatment to really improve the efficiency of your treatment and, you know, help your practice, help treatment plan it, help talk to your staff and engage your staff, the Gallery Engage convention at the end of July, again, where Anna Berik is speaking, is a great, great place. There'll be many speakers regarding this topic, and it is at the AACA website. So if you look up AACA, you will find all the information there. And thank you very much.